Hello, everyone. So as you enjoy lunch, I would like to introduce our first speaker. We have two speakers during the lunch break, two great speakers, and it's my honor and privilege to introduce Dr. Mack Mitchell as the first speaker of this session. Dr. Mitchell is professor and executive vice chair of internal medicine at UT Southwestern. He's the chief medical officer for UT Southwestern's Accountable Care Network and Associate Vice President for Population Health. He earned his medical degree from Johns Hopkins University School of Medicine and served as Chief of Gastroenterology and Medical Director of Ambulatory Services at Johns Hopkins Bayview, Chairman of Internal Medicine at Greater Baltimore Medical Center, and Chairman of Medicine at Carolinas Medical Center in Charlotte, North Carolina. Dr. Mitchell currently serves as Chief Medical Officer for Southwestern's Health Physician Network. And today we're very fortunate that he's going to provide a presentation entitled Population Health and the Importance of Screening. Dr. Mitchell.
Ivan, thank you very much for that nice introduction. Let me say first, good afternoon, and it's a pleasure to be here talking with you about where we are headed in population health. And in doing that, what we realize very quickly is that screening is one of the important elements in population health. You've heard several examples of how screening has been used for specific problems such as detection and diagnosis of prostate cancer, detection and diagnosis of colorectal cancer, and detection and diagnosis of many, many other things already this morning. What I'm going to try to do is put that in the perspective of where all of these things fit into our population health efforts. So one of the first questions that I'd like to pose is, healthcare reform in Texas? Why now? I mean, what has changed? What is it that's driving the shift that we're all experiencing in both the payment systems and also even in the models of care that we deliver to our patients? I think that you all would probably agree with me that medicine has become a lot more complex. It's certainly much more complex than it was when I finished medical school. And I found a few interesting factoids when preparing for this, one of which is that physicians in practice today interact with as many as 229 other physicians in almost 117 practices just to take care of their Medicare patients. ICU clinicians are performing almost 200 activities per day on each individual patient, and a patient with a chronic disease that's 79 years old may have not one, but 2 or 3 different chronic diseases that require up to 19 medications per day. The second thing that has happened, I think we also appreciate, and that is the increasing cost of healthcare. This graph shows the rate of increase in workers' earnings, the rate of increase in overall inflation, and the rate of increase in healthcare premiums. The healthcare premiums are increasing at a rate that is much higher than that of the wages and also of inflation. And those things combined, increasing complexity and increasing costs, are what are leading us to try to take a look at what we might do differently and how we might organize the delivery of our services in a different fashion. I put this slide up not to actually point at Dallas and Houston and other places in Texas as being high in cost, but to point to this as an opportunity for all of us to make a significant contribution to controlling costs, but also matching the services that we deliver to the needs that our patients have. And I think as we look at healthcare and what we're being asked to do today, we are being asked to improve the health of a population that we're responsible for, improve the experience that that population has in receiving the care that we deliver, and also making that care affordable. The challenge, as you can see on the left-hand side panel of this slide, is that we also recognize that 20% of the people in the population that we serve account for almost 70 or 80% of the cost. So it's the so-called 80-20 rule. 80% is consuming 20% of the care, 20% is consuming 80% of the care. Now, the problem is identifying who's at risk, because if you simply wait until the risk has occurred, you have far less opportunity to act on that. So when we talk about population health, we're really talking about using data to drive the decisions that we're making. So I think as we look at population health, what we need to understand is that those population health efforts need to be patient-centered, they need to be data-driven, but they need to be led by all of you in the room. They need to be led by the people who are actually providing the care. I don't think that anything is going to change or get better if we simply wait for the federal government or various other entities to define what it is that we need to do. But we know what that is that we need to do. We know that we need to collect data to measure the improvements in care, to measure accountability, and also to use these same measurements to improve our overall understanding and to point to new directions where we ought to be focusing our research efforts. So measurement is really key to success in population health. Now, when we talk about measurements and quality, we really need to understand what does that really mean. And most payers today, including CMS and most commercial payers, are incorporating measures of quality and performance into the contracts that they have with us for delivering care. Now, you heard Dr. Rofsky earlier today talk about the changes under the macro legislation and the move away from PQRS to the MIPS program. So there are some clear differences in MIPS compared with PQRS, but largely they are two ways of getting at the same goal, which is to measure performance and measure outcomes. So of the 33 measures that we use in the Accountable Care Organization to look at our performance, 1/3 of those measures really are based on screening, which is what I'm going to turn my attention to in just a moment. 1/3 are based on outcomes, and 1/3 are based on patient care and the patient experience and care coordination. So the Institute of Medicine recently concluded a study on population health, state of the art, where we are, where we're headed. And what they recommended is that CMS should continue to test payment reforms that encourage coordination of care, real-time sharing of data, and tracking of patient outcomes, as well as encouraging those of us who provide care to assume a portion of, or at some point in time, the entire risk associated with providing the services. Now, whether we will get to that point where we are assuming the entire risk for the population has yet to be seen. Risk is synonymous with insurance, and today I don't think that most of us are prepared to become an insurance company, so we are looking at our ability to share risk in a much different way than an insurance company might. But one of the things that's driving this is a change in the way in which we get reimbursed for the care we provide. And we know that we're moving away from fee-for-service towards a fee-for-value model, which at its final endpoint, as Dr. Rofsky said earlier, a true capitated payment system. Now, the thing that is important also to recognize is that when you go from this fee-for-service model to a truly capitated model, or even a model in which risk is shared among the providers, there's a big requirement that comes with that, and that requirement is clinical integration. Now, it's not really essential that you have a high degree of clinical integration in a fee-for-service model, even though it might be desirable. But in a shared risk model, it is essential that you have clinical integration, meaning all of us as physicians and providers of health care coordinate the efforts that we're making, share the information, and really keep that patient in the center of all of the efforts. So to accomplish that, over the last few years, we've been looking at how to develop the right model for delivering care. And we started a number of years ago, as many of you know, because you are participants in our Accountable Care organization. We started with the development of the UT Southwestern Accountable Care Network, all the way back in 2013. And over the last few years, as the network increased in size and as we added members from the Texas Health Physicians Group, we reached a point that we recognized that we really did need to become a truly clinically integrated network to deliver care. So we now have three main elements in Southwestern Health Resources, which actually started doing business as Southwestern Health Resources almost 1 year ago today. And we have the three main components being the physician network that comprises all of the UT Southwestern faculty, along with all of the Texas Health Physicians Group, and all of those folks in the community who are members of the UT Southwestern Clinically Affiliated Physicians Group. That's really the center. This physician network is the center of Southwestern Health Resources, but we're also fortunate to have now a network of facilities in use of the THR facilities as well as the UT Southwestern hospitals. In addition, we are developing a population health research center that will allow us to see whether the efforts that we're making are having the desired impact on the health of our population here in North Texas. It also is facilitating things like this meeting today, where we can bring everyone together collectively to talk about important changes and important updates and how we most appropriately use imaging tests and various other things that we're going to do for our patients. So all of our continuing medical education efforts are being linked together. All of our undergraduate and postgraduate medical education is also being linked together. Now, a lot of you have seen this slide before, and if you have your binoculars on, you might even be able to find the dot on this map that represents your practice. But what I want to do is to make sure everyone understands that we are focusing care not just in Dallas, but across the entire Dallas-Fort Worth area. This is a large geographic area, and it presents some challenges for us, but it also presents tremendous opportunities. We've also matched that up with the facilities that we have where care can be delivered on an inpatient basis or even on an ambulatory basis, and those are shown as well. Now, I needed to update this slide, which I didn't do, because that number of physicians in UTS CAP has grown from 273 to now 320 just over the last 6 months of time. So this is a dynamic and evolving network, but we're very proud of that, and we're also very thankful for your participation in this network. As a network, we've been able to accomplish a lot of things that I don't think any of us would have been able to do as individuals. And this slide is one example. It shows that beginning in 2014, if we looked at an overall composite score of our quality measures, we were sort of around the 50th percentile, but we have quickly, over the last 3 years, climbed all the way up to the 75th percentile. We don't plan to stop there. We really do want to be one of the best in the country, and so our goal is really to get up into the 90th percentile for all of our quality measures. And a lot of that does come down to screening as well as the other outcomes of care. We also now are responsible for managing almost 330,000 different people when you include our Medicare Shared Savings Plan, which is now a next generation ACO that has almost 80,000 Medicare beneficiaries, along with another 250,000 people who are in commercial insurance products. That's getting to be a very large number. Now, I'm also happy to report, as again many of you know, that we have been able to succeed in reducing the cost of care at the same time that we were improving the quality of the care that has been delivered. And if you look at the right-hand panel, you will see that before this line in 2013, Medicare was very good at predicting what our cost of care would have been. Our cost of care is that red line. Medicare's actuaries said that our cost of care would be the blue line. But what you see in 2014 and 2015 is those two lines start to diverge, and that accounts for a 4% overall savings. Now, 4% doesn't sound like a big number until you realize that's 4% of a huge amount of spending in this Medicare population, which then comes out to almost $30 million. So those are the kinds of things that we can achieve working together as part of a clinically integrated network. So let me now focus a little bit more attention on screening. And when we talk about screening, what we're really talking about here is identifying risk factors for disease, hopefully at a stage that's early enough that we can make a difference. But there are some pitfalls in screening, and I'm going to try to identify what some of those are. So screening tests could be biological measures. Genetic factors are becoming increasingly important. We know that there's genetic factors that are responsible for a lot of chronic diseases. They could also be around behavior, and we know that behavioral factors contribute a lot to the development of disease. They could be environmental, where you live, what kind of facilities are close to your home, whether you're in a food desert. And these socioeconomic determinants, income, employment, education, access to health care, we know are important. We don't have great ways of measuring those other than by zip code right now, but we're getting better at that. And by screening for a lot of those kinds of things, we may be able to better identify the rising risk populations. So let me start talking about screening by saying this is not a trivial problem. And I was kind of interested to see that when I hit screening tests in PubMed, there were 100,000 publications on screening that have been published in the last 5 years. Now, I will promise you I didn't read many of those, but I did take a look at some of those. And I think a lot of what I found was that there's arguments both in favor of and against the use of screening tests, and they're highly statistical in the way in which these arguments are. It is clear, though, that a lot of the screening tests are best designed for subsets of the population, not for the entire general population. So we need to appreciate that one difference. We also recognize that a lot of the ability that we have to order screening tests depends entirely on someone's insurance plan, because some payers will pay for one test and others will not pay for that test, and vice versa. So the characteristics, therefore, of a good screening test are ones that identify a risk factor or a disease process that could adversely impact health. But it assumes that there is an intervention associated with the screening that, if you detect the disease or the risk factor in an early stage, can actually be acted on, so that there's no reason to screen for an untreatable condition unless people simply want to know. Huntington's disease would be an example. We could screen the population, but in all honesty, we still don't have a way to intervene, so that wouldn't probably be an effective way to proceed. But the interventions have to do something that modifies the natural history of the disease. You heard a good example earlier, identifying polyps and taking them out before they have a chance to progress to cancer. That's one example of a screening test that leads to an intervention. We also don't want to detect things that are either untreatable, and we certainly don't want to detect things that don't require any treatment, that just produce anxiety about the patient knowing that they have this condition. And lastly, the screening test needs to be cost effective. So there are some harms, potential harms, and limitations associated with screening that we need to be aware of. Number one, there are always false positive tests. And you got to figure out how you're going to deal with a false positive test. And what that means typically is that there's going to be a series of other tests done before you even know that the test is a false positive, and you may create unnecessary care for a non-existent condition. There's also harm that can be associated with certain screening tests, and I'll use colonoscopy as an example. As a gastroenterologist, I recognize very clearly that anytime we do a colonoscopy, there is a chance for an adverse outcome. And it's important that not only I understand that, but also that my patients understand that as well. Communicating those risks to the patient in a shared decision-making form is necessary. There's also risks associated with false negatives. Someone could be falsely reassured that they don't actually have a condition when in fact they do. So these are the things that I would say are the dark side of screening. So when we look at what's the optimal frequency of screening, there is a point where you can screen at the right intervals and therefore get the best outcomes in terms of the highest value of the screening. But if you continue screening, or if you make the intervals of screening too short, then you might actually run into a scenario in which there's actually more harm associated with the screening than there is value. That's the scenario that we want to try to avoid. So to remember that, it's a little bit like the Starling curve that we all learned about in medical school. You reach this point of maximum performance, and then things tend to degrade on the back end. So I would advise everyone to think about not only the type of screening test, but the interval of screening that you need to be thinking about. And so there's a lot of questions then that emerge, including, should we screen less frequently? What do we do after you get a negative result? Should we stop screening people who don't have much life expectancy? Should we just screen only older individuals or those who are at very high risk for a problem? And lastly, we've got to figure out how to use the screening tests and apply the principles that we know about sensitivity and specificity. I'm going to skip over this information on colon cancer screening because you all heard that described very well by the last speaker. Then finally, where we are with the ACO in terms of recommendations for screening. I think it's important to know that blood pressure screening is important. It's vital to reduce risk for cardiovascular disease. Lipid profile screening is also vital for not only patients' cardiovascular disease, but also in terms of the management of their diabetes, which is important in cardiovascular risk. But then there's things like screening BMI, screening for falls and depression that have become quality measures within the ACO that we need to be aware of. And then lastly, what I want to do is remind all of us that in this era where there's a lot of focus around the cost of care, that we still need to remember that as physicians, we need to be concerned about the primacy of patient welfare and that we are dedicated to serving the interests of our patients and not allow market forces to compromise that principle. We also need to recall the importance of patient autonomy and engage in informed decision-making with our patients so that we can avoid inappropriate care. And then lastly, remember the principles of social justice, which entrust us with the responsibility for the fair and just distribution of those finite resources that we have in healthcare. And if any of us think that these are new principles, we should only look to Sir William Osler, who back in 1893 observed that medical care needs to be provided with utmost efficiency because to do less is a disservice to those we treat and an injustice to those whom we might have treated. So I'm going to finish here. Our next speaker, Joan Porter, is going to be talking with us about how we should think about adhering to principles and guidelines, particularly within the construct of the ACO. And I'll get Ivan to introduce her. Thank you.